Doctor, we're talking about hormone replacement therapy, which is something that has been controversial, about which there's an enormous amount written in the consumer magazines. There's just a lot written about hormone replacement therapy. What is it?
You've come into the debate. Hormone replacement therapy was the old unfavored term, and the idea behind that was that as a woman went through the menopause, her ovaries stopped making enough estrogen, and so the idea behind that was to replace the estrogen that she should have been making out of her ovaries with estrogen from another source. Now, going back to the 60s, 70s, and 80s, the most common source for that was pregnant mare urine, Premarin, very reliable source, very well studied. Other techniques came along where they manufacture the estrogen out of yams or other products, soy. Those are other areas that you use to manufacture the product. But those were the sources for hormone replacement therapy. Now, the hormone replacement therapy got revised with the results of the Women's Health Initiative in 2002 when they were evaluating what they had studied at that point. I like to look at hormone therapy from a couple of components. One of them was that the Women's Health Initiative was trying to impact heart attack and heart disease. That was brought forward in the late 80s and the early 90s as a big study medical study that would evaluate what happens in women. Now, the WHI, as it's commonly known, eliminated all women who had menopausal symptoms from the study.
Well, then what are the current guidelines for hormone replacement therapy?
It kind of depends on who you look at. The tightest guidelines coming out of the North American Menopause Society are lowest dose, shortest duration of time for basic things like vasomotor spasms, hot flashes, urogenital atrophy. That's just the dryness that women get in those areas. And so those are the current guidelines. Along the way, we have we still have prevention of osteopenia as a treatment for low bone mass. But those are the strictest guidelines.
As a woman ages, what are the pros and what are the cons of hormone replacement therapy?
The pros and cons basically work out into those people who believe that you should only take the minimal amount of therapy for the shortest period of time. Now, I'm a pro. Other of my colleagues are cons. In any case, the number of bad outcomes that were all summed together still are in the uncommon range. It doesn't happen often. The number of extra breast cancers in the Prempro group, the group that had the Premarin and the Provera together, still only qualified as 8 per 10,000 women per year. That is a rare occurrence. That small number, in the opinion of the World Health Organization, is rare. Now, if you're evaluating what happened to a grandmother who was on the Premarin and she had a breast cancer, well, the number of extra breast cancers due to the Prempro was 8 per 10,000 women per year.
Okay.
So, didn't happen often, just a very small amount.
Well, so that is your argument in the pro, but let's take the advocacy position. What's the argument in the con?
In the con, they say, we don't need this, we're only going to treat, we're going to do no harm. And as a result of the Women's Health Initiative, the physicians who wanted to do no harm looked at the whole group. The debate that we have had since the WHI came out is that we doctors have now looked at what happened to the women in the 50s, what happened to those women who are in their 60s, what happened to those women who are in their 70s. The Women's Health Initiative lumped all these women together, and when they broke out their initial data, not the women across all 30 years had a net reason to stop the medicine and stop the study. The epidemiologist said, we need to stop this is not good. But we gynecologists remember that we were only treating our patients for menopausal symptoms. We weren't using Prempro as a heart drug.
Well, then what should a woman who is experiencing menopausal symptoms do?
Talk with your physician. I will trust your relationship with your physician, your gynecologist, your internist, family practice, your nurse practitioner, and work with what symptoms you have. There are a lot of good drugs out there. I like the orals are good. The orals are inexpensive. They're cheap. They're available. The transdermals are probably slightly cleaner.
You mean a patch?
A patch.
Okay.
A patch or a foam or a cream or a spray.
Okay.
There are a lot of transdermals that are out there. And the transdermals are the purest estrogen that is out there. Now, the Premarin tablet has been around for 50, 60 years, and it's very reliable. We have a lot of information. And in fact, there are some benefits to Premarin that we don't get with the patch. In any case, I'm more inclined for a patient to go with what they're going to use, what's going to be easiest, what's going to be most comfortable, and accept the risks.
So how does a woman make a decision about whether or not to take hormone therapy?
As I look at the data of what happened in the WHI study, when we looked at the women who were compliant with their pills, that is, when they were taking at least 80% of the tablets, they were taking the pill 6 days out of 7.
Mm-hmm.
And these were the women in their 50s. Then in those women, I see the risk factors are deep vein thrombosis and pulmonary embolus. And that's a small amount.
Define both of those for those watching.
A pulmonary embolus is a blood clot that goes to the lung.
Okay.
A deep vein thrombosis is a blood clot in the leg.
Okay.
You've heard your friend flies to Paris, she sits on the plane for 10 hours, gets dehydrated, and all of a sudden she's got a blood clot down her calf. Mm-hmm. If it stays there, that's deep vein thrombosis. If it flips away, goes in, comes out to the lung, that's a pulmonary embolus.
Okay.
Happens about 4 per 10,000 women per year. I think the research that I like from a friend of mine in California named Howard Hodis, Hodis, shows that women in their 50s, 40s and 50s who are on hormone therapy get the benefits of diabetes, heart disease, less progression of calcification in the coronary arteries. Okay?
All right.
Those scores in the 50s. Skin, cognition, being able to concentrate, better sleep patterns, better sense of well-being, fewer hot flashes, getting you down to where you just have one hot flash or less each day, improvement in the bone, osteoporosis,
okay.
urogenital health, keeping that area healthy, keeping the area loose, compliant, elastic, maintaining health in those tissues, skin, vital skin, keeping your skin healthy, vibrant. I like the benefits that hormones give because we even know that women in the WHI study had lower rates of diabetes. You were less insulin resistant. Long term, from the women who took hormones back in the 60s, 70s, and 80s, they had better teeth. You found isolated studies in which women had better hearing. You found small groups of people who suggested that maybe things like age-related wet macular degeneration, cataracts, those are all small studies. Now, they weren't addressed in the WHI, but I look back and I see all these things making a difference. The take-home is, for a woman in the 40s and 50s, I think estrogens are okay. If you've been on them, talk them over with your doctor, evaluate how you want to go for another year, and see where you want to go. I do not recommend women going back on 10 years beyond. If you've been 10 years without hormones, that's too late. I don't think you're going to benefit except in specific areas like urogenital atrophy, keeping the tissue down there, bladder, vagina, keeping that area healthy.
Okay. Doctor, thank you very much.
Thank you.